Respected seniors, dear colleagues, I am Dr. Sonosekhar Lama, third year resident of Manipal Teaching Hospital, Pokhara. Today I am going to talk on the topic of study of role of open reduction and internal fixation with volar locking plate in management of distal radius fractures. Distal radius fractures are the most common fractures encountered by orthopedicians. It accounts for 17.5% of all fractures. In elderly, it is mostly caused by fall on standing height with low energy trauma, and in young population mostly by high energy trauma. Distal radius fractures were mistaken for dislocation of wrist during Hippocratic era. Petit, Patau, and Colles were first to describe distal true nature of distal radius fractures. Barton in 1838 described partial articular fractures. Malgagny in 1847 explained distal radius fractures from fall from palmar aspect of the hand, and Smith described distal radius fractures from fall from dorsal aspect of the hand. All the fractures were classified according to AO classification. There are also other classifications. According to AO classifications, A is extra-articular, B is partial articular, and C is complete articular. In earlier days in the history of distal radius fractures, there were debate on treatment protocol. Opredeni in 1929 first reported the use of non-bridging external fixature. Roger Ederson and Gordon O'Neill in 1944 introduced bridging external fixation, castless fixation technique. Vidal et al. Was the first to give the concept of ligamentathesis. Lombardi was the first to design radial salad pin for distal radius fractures. Percutaneous pinning with multiple pinning technique gained popularity for a long time. After plating came into use for distal radius fracture, it was first mentioned by Ellis in 1965. Initially, dorsal plating was developed, and after that, volar lock plating came to use and still is in use today. There are various treatment options in which close reduction with class application, percutaneous K-wire fixation, internal fixation with dorsal or volar lock plating, and external fixation. Main aim of this study is to review the surgical outcome of open reduction and internal fixation for volar lock plating for distal radius fractures. Advantages of open reduction with volar lock plating are to restore normal anatomy and biomechanics of distal radius, good functional outcome. This is a prospective observational study. 81 cases were taken into account. We did this study in Manipal College of Medical Sciences Teaching Hospital, Department of Orthopedics, Pokhara, Nepal, and duration of 18 months. Inclusion criteria were patients from 18 years of age of either sex, patient presenting within 2 weeks of fractures, extra-articular and intra-articular distal radius fractures, failure of close reduction and cast application, type 1 open fractures of distal radius. Exclusion criteria were type 2, type 3 open fractures, unstable intra-articular distal radius fractures with combination, patient with impaired wrist function prior to injury, patient unwilling or incapable of following post-operative physiotherapy, patient unwilling to give consent for participating in this study. Surgical procedure where patient position supine with arm abducted in 90 degrees, supinated and placed on arm table. Tourniquet was applied on the arm, upper arm. Fracture was opened by modified Henry's approach. Hematoma was cleared, fracture was reduced, and volar locking plate was fixed with screws. Tourniquet was removed, hemostasis was secured, and whose wound was closed in layers. Below elbow slab was given with a sling. IV antibiotic was given for 3 days. Patient was hospitalized for 3 to 5 days. Post-operatively, movement of fingers were started. Wound was inspected periodically and staples were removed on 14th post-operative day. Slab and sling was discontinued after 2 weeks and full range of motion was started. At 6 weeks, post-operative radiograph was taken to assess bony union. Routine physical activities was allowed after satisfactory fracture healing. At 12 and 24 weeks, clinical and radiological progress was assessed. Functional outcome was evaluated at 12 and 24 weeks by patient-weighted wrist evaluation scoring system, which had penny score of 50, functional score of 50, total of 100, in which lesser the score, better the outcome. Among the patients, mean age was 48.47 years. Mean female was highest in account, and left side was involved more than the right side. Fall on outstretched hand was most common mode of injury, followed by domestic fall, then road traffic accident and others. Mean time of injury to surgery was 6.23 days. Average duration of the surgery was 52.81 minutes, and all the wound healed in 14 days. Superficial infection was seen in 2 cases. 2 cases had hypertrophic scar, and 5 cases had wrist stiffness. According to AO classification, A2 fractures were seen in 21 cases, A3 in 14 cases, B3 in 3 cases, C1 in 36 cases, and C2 in 6 cases, and C3 in 1 case. Mean preoperative radial height was 5 mm, which improved to 9 mm. Mean preoperative radial inclination was 13 degree, which improved to 17 degree. Mean preoperative ulnar variance was 0.20, which improved to 0. Preoperative dorsal or palmar tilt was 9 degree, which improved to 0.60 degree. Mean PRW score at 12 weeks for extra-articular fracture was 37, which improved to 18 in 24 weeks. For partial articular, it was 36, which improved to 15 in 24 weeks. And for complete articular fractures at 12 weeks was 38, which improved to 24 weeks. All were below 50, which has good functional outcome. Distal radius fractures were initially treated according to the mechanics of reduction, immobilizing position, and splint, which had poor outcomes. After the external fixation and percutaneous pinning with multiple pinning techniques gained popularity for a long time. Later, plating came into use, initially dorsal plating, and after that, volar lock plating came to use and is still in use today. In our study, most of the patients belong to the mean age of 48 years, which were comparable with the study of Paraniva and Joss and Dilliam et al. Incidence of distal radius fractures was highest in females, which was comparable with the study of Paraniva and Chavan et al. And most of the females were postmenopausal. In our study, 9 patients developed postoperative complication. 2 had superficial infection, which healed with oral antibiotics and dressing. 2 had hypertrophic scar, and 5 had wrist stiffness due to poor patient compliance, and after physiotherapy, it improved. The postoperative radiological parameters were comparable with the study of Maas, Hemant, Rizzo, Rowe, and Wilkinson, Giaz et al. In this study, patient rated wrist evaluation score at 12 weeks and 24 weeks were comparable with the study of Aurora and Dilliam et al., which were below 50 with better functional outcome. According to AO classification, PRW score at 24 weeks for extra-articular fracture was 18, for partial articular fracture was 15, and for complete articular fractures was 19, which was comparable with the study of Van Ledam et al. So I want to conclude that volar lock plating had distinct advantages for displaced radius fractures. Open reduction and internal fixation with volar locking plate ensures accurate anatomical reduction and stable fixation, early mobilization and return to function, low complication rate, and functional results of volar locking plate are excellent and promising. These are preoperative and postoperative X-rays. This is the functional outcome of the patient in 24 weeks with good dorsiflexion, palmar flexion, supination, pronation, ulnar deviation, and radial deviation of the wrist. Thank you.